cramping. Risk for fluid volume deficit related to loss of fluid caused by diarrhea. Risk for altered nutrition, less than body requirements, related to the need for a liquid diet to rest the bowel. Impaired skin integrity related to irritation around the anus from diarrheal stools. Anxiety from the inability to control bowel movements. When treating diarrhea, it is important to remove the precipitating factors, stop the diarrhea, and avoid or treat fluid, electrolyte, and acid-base imbalances. What is the most common acid-base imbalance with diarrhea? Metabolic acidosis, because the client loses base via diarrhea. Remember that the interventions for managing diarrhea vary with the cause. Administer antibiotics if the diarrhea is of bacterial origin. Instruct the client to eliminate foods that are irritating to the colon if the diarrhea is caused by a food allergy. Have the client keep a food diary if uncertain about which food is causing the diarrhea. Administer antidiarrheal medications such as loperamide, hydrochloride, that's Imodium, as prescribed. Codeine, an opiate, is sometimes used to control severe diarrhea. These antidiarrheal medications should not be administered for prolonged periods. Provide a liquid diet for at least 8 hours to rest the bowel. Then encourage frequent small feedings of high protein, high carbohydrate, low residue foods such as steamed chicken without skin. Foods high in fat, milk, and seasoned meats are high residue foods and should be avoided. Foods with bulk should be added very gradually. Clients who are dehydrated due to diarrhea may require IV infusions to restore fluid and electrolyte balance. For clients who have less severe dehydration, drinking an oral electrolyte solution, such as Gatorade, may help. To prevent excoriation or skin breakdown around the anal area, gently wash and rinse the skin after each bowel movement. Pat the skin dry and apply a medicated ointment that contains vitamins A and D or zinc oxide. Remember to consider the emotional needs of the hospitalized client who has diarrhea. Provide privacy if the client must use a bedside commode or a bedpan. Empty the bedpan or commode as soon as possible after use, and then, if the client wishes and no one in the area has any pulmonary conditions or sensitivities to aerosolized chemicals, spray the room with an air freshener. Now let us move on to constipation and fecal impaction. Constipation is a general term for bowel movements that are unusually small, hard, dry, difficult to pass, or infrequent. A serious complication of constipation is fecal impaction. A fecal impaction is a mass of putty-like or hardened feces that collects in the rectum and prevents the passage of normal stools. What are some of the causes of constipation? They are inadequate fluid intake, inadequate bulk in the diet, sedentary lifestyle, poor bowel habits, such as ignoring the urge to defecate, immobilization due to illness or injury, medications that slow intestinal motility, intestinal problems that obstruct the passage of stool, overuse of laxatives, and aging, which slows peristalsis and, for some people, decreases activity levels. Signs and symptoms of constipation include straining at stool, abdominal bloating, abdominal discomfort, and a feeling of rectal fullness. The client who is developing a fecal impaction may experience diarrhea because stool liquefies in order to pass around the hard impaction. It is important to check the client's stools to determine if they are hard and dry. Examine the client's abdomen. Does it appear distended? Listen for bowel sounds. If you suspect fecal impaction, perform a digital examination of the rectum and feel for the presence of a hard mass. Inspect the rectal area for redness, fissures, or hemorrhoids from straining at stool. The primary nursing diagnoses for clients who have constipation are constipation related to a change in bowel habits, pain related to difficulty in passing stools, risk for fluid volume deficit related to inadequate fluid intake, and anxiety related to difficulty in passing stools and fear of fecal impaction. Medications that are used to treat constipation include stool softeners, such as Docusit sodium, that's Colace. Also used are bulk-producing laxatives that contain psyllium, such as Metamucil, and stimulant laxatives like Bisocodyl, that's Dulcolax. A severely constipated client might require the insertion of rectal suppositories or the administration of an enema. An impacted stool might have to be removed manually. It is important to instruct clients about how to prevent constipation. Suggest that they record their daily intake and output of foods and fluids. Drink 8 glasses or more of water and fruit juices daily. Include more high-fiber foods in their diet, such as whole grain cereals, raw fruits and vegetables, and products containing bran. Schedule some time to exercise every day. Walking is an excellent exercise. If possible, respond right away to the urge to defecate and allow enough time to have a bowel movement. Try to establish a routine time each day for bowel elimination. For many people, the best time is after meals. Avoid straining at stool because straining can cause serious heart problems as well as hemorrhoids. Avoid the overuse of laxatives, suppositories, and enemas. And finally, if constipation persists, they should consult with their primary care provider. Gastrectomy is defined as a partial or total resection of the stomach, done to correct the underlying problem and eliminate the gastric disorder. Indications for gastrectomy include malignant tumors and gastric ulcers that fail to respond to lifestyle changes or medical interventions, or are complicated by hemorrhage or perforation. What are some of the signs and symptoms that indicate the need for a gastrectomy? The symptoms include sudden acute epigastric pain, a rigid abdomen, vomiting blood, severe anemia, and shock. A gastroscopy will verify the need for a gastrectomy. Types of gastric surgery include gastric resection, which removes the lower half of the stomach, total gastrectomy, which removes the entire stomach, pyloroplasty, which enlarges the pyloric sphincter of the stomach, thereby decreasing pyloric obstruction and promoting gastric emptying. Vagotomy, which involves cutting the branches of the vagus nerve, thus decreasing vagal stimulation of hydrochloric acid secretion in the stomach. Billroth 1, which removes the distal portion of the stomach. And finally, Billroth